about choosing an AR antagonist versus like abiraterone, what sort of factors into decision making? Is reimbursement an issue? Is it more about comorbidities or other drugs they're taking?
I think reimbursement is an issue. So something like relugolix, I've had some issues with, and it's often just easier to use Lupron, and well, easier, and also, I mean, obviously much more feasible for the patient than having to deal with significant copay. That's at least been my experience.
Yeah, I mean, for me, the difference between agonist and antagonist is significant in monotherapy, but we don't really know once you apply a combination with a powerful drug like an AR pathway inhibitor whether it still matters. But we did have a poster from the optics registry showing that patients choose relugolix because they really like to have an oral option. And I do have a lot of patients who don't like to get injections, which surprises me. But physicians, I think, are a little more in tune with testosterone suppression, testosterone recovery, and we might use it more kind of in earlier disease states and less in the long-term metastatic setting. I don't know, any thoughts on agonist versus antagonist?
I agree with everything you guys are saying. I think relugolix is a nice drug when you're worried about T recovery, like when you want quick T recovery afterwards. I think that's its biggest strength. And then the discussion around cardiovascular risk, I kind of always say that if there was a very big difference between these two drugs, we wouldn't have been discussing it for 20 years. It would be obvious because we've talked about this for 15 to 20 years. And when there's big differences, it's clear. And so I don't think the difference is so profound, but maybe it matters when you're seeing that man here going to give ADT monotherapy because they're frail and you're worried about T recovery and they have some pre-existing either cardiovascular disease or a lot of cardiovascular risk factors. I think that makes sense there. I totally agree. There's a nice systematic review and meta-analysis published in the UK that showed that the odds ratio for layering on an AR pathway inhibitor is it's basically an odds ratio of 2 for a major adverse cardiovascular event. So there's a tiny difference between agonist and antagonist, and then this big layering on top. So if you're going to do doublet like we do for most patients.
Yeah. Apropos to that, I think when you choose a drug, age does matter. Then patients would have cardiovascular problems or elderly, you don't really want to give abiraterone to because of the fact that people can have more cardiovascular events. And what bothers the doctors is also liver function abnormalities. So they have to come in. We have people come in every 2 weeks, or they have at least do their labs and send them in when they first start abiraterone.
I'll make one more comment on the relugolix. The place I find it to be particularly useful is every once in a while you meet that patient who's getting radiotherapy, you're going to use ADT going along with it, and they're very reluctant about the ADT. They're uncertain about the side effects, and they want a treatment option that's going to be quick off, like you say. So, rather than patients deferring ADT altogether, I say, all right, I've got another option for you. This is an option that, say you have the side effects from ADT and you want to stop it, we'll have quick testosterone recovery afterwards. I find it to be particularly useful there. HERO, like you said, does raise some signals for maybe some differences in cardiovascular events between the agonist and antagonist, so I'm particularly likely to use it if I'm using it as a monotherapy and somebody's had a recent cardiac event. And then you bring up another point that's so important is we're rarely using ADT alone now. It's usually with an ARPI, and we don't have great data, but there is some pharmacovigilance data and some other studies from the VA and other places that suggest that maybe abiraterone has slightly more cardiac risk as compared to the lutamides. There's more we need to do there, more that needs to be learned, but I'm already considering those things in practice.
Yeah, I agree. And I feel like maybe we should be involving cardiology a little bit earlier, unless we're going to take on more comprehensive management. I mean, I was impressed to hear urologists talking about checking A1Cs and not just bone density, which I think most medical oncologists are in tune with, but really that cardiovascular management, taking some ownership of that was pretty interesting.
I'll add in too. I think that a lot of people have talked about the PRONOUNCE trial, which was aiming to primary endpoint looking at major adverse cardiovascular events of agonists versus antagonists, stopped early due to slow accrual and low number of events. And some people say, well, this problem isn't a problem. But what that actually tells you is every single patient on that study met with a cardiologist prior to initiation of ADT. And my interpretation of that study is meeting with a cardiologist is really important to mitigate your cardiovascular risk. And we need more and more buy-in there, especially since I think a lot of us, just like how prostate cancer medical oncology has changed a ton over the last 5 years. Management of cardiovascular risk is complicated. It's not something most of us can keep up with in the clinic.
Right.
So I fully agree with you.
Well, and along those lines, I'm just curious among our panel here, do you guys standardly involve cardiologists and at what point during, like treatment of these patients?
The majority of my patients already have a cardiologist when they come in. It's rare that they don't to have one, but I think that sometimes I speak to them before I start any kind of therapy.
My approach when I meet patients in clinic, you're covering so much in that first visit, the treatments you recommend, the side effects, potential toxicities. Then when you start getting into trying to modify their cardiac risk in that first visit, it's a little bit overwhelming. Same with bone agents. So usually I bring them back for that 1 month toxicity check after you started something, and that's when I get a bone mineral density as well, and then start talking about setting up an appointment with your primary care doctor to check your lipids and A1C, et cetera.
For me, we'll get lipid panels and hemoglobin A1C at the first visit, and we try to check it annually and calculate ASCVD risk score from that. When I send to cardiology, I mean, if someone has pre-existing cardiovascular disease, we have a number of cardio-oncologists at our institution, so I'll try to send them at that point and make sure that we're staying on top of things. Otherwise, I think if I see a big increase in cardiovascular risk from hormone therapy, I'm quick to send them. Otherwise, I try to let internists take over at that point, like you guys referred to.
Yeah, that's generally, well, that's, a lot of that is my approach as well. I mean, being at a kind of tertiary academic center, like we're privileged in some way to have colleagues like in cardio-oncology, right, to refer many of these patients to. So I try to really utilize that.
I do try to be careful about drug-drug interactions because they are different between abiraterone and the AR antagonists, and even among the AR antagonists. So I do try to run that list and make sure that what I want to prescribe will fit. Here at this meeting, Alicia Morgan's had a poster on cognitive function, a prospective trial where cognitive testing was done in patients receiving abiraterone and patients receiving enzalutamide, and really didn't see a difference. And I feel like
that was amazing.
Something
that was an interesting
we
poster. I saw it too.
perceived in our practice that could be different. Are there any other side effects between Abi and the lutamides that lean you towards one or the other drug?
I'll tell you, so Dr. Morgan's presents like another important finding at this meeting, and it kind of fits a little bit with what we saw with Odenza before, right? Different disease setting, but with Odenza, you had patients with metastatic castration-resistant prostate cancer that were exposed to both darolutamide and enzalutamide, and it was a patient choice or patient preference. And at the end of that, there was no difference in patient preference between the two. There was a slight trend toward more patient preference to darolutamide, but not as much as I would have thought. And patient preference was really driven by the presence of fatigue, which I also would have thought might have been higher with enzalutamide. All of this makes me wonder, are my impressions in clinic wrong, or do we not have the right tools to assess these patients?
Right.
Maybe you're right about the tools, but I thought that enzalutamide had more falls and fractures than abiraterone, and I worry about abiraterone with the cardiovascular problems. But some of my patients really can't take the enzalutamide, and I'd have to switch them to abiraterone.